I was actually just looking at the electron micrographs in chapter 35 of Murray's Medical Microbiology this morning. And honestly, it looks like something straight out of a sci-fi movie.
Oh, yeah, it really does.
You have these massive, distinct shapes inside a human cell. They're almost pushing the host nucleus completely to the side, just packed full of bacteria. And the text describes chlamydia not as your standard infection, but as a stealth pathogen.
I mean, that is the perfect description for it. It really challenges the strict definitions we usually rely on in microbiology.
Right, because usually we draw a pretty hard line.
Exactly. We say, okay, bacteria are free-living. They have cell walls. You can grow them on agar plates. And then viruses, well, they are obligate intracellular parasites that absolutely need a host cell just to survive.
But chlamydia sort of just...
It's right on that line. It's technically a bacteria, but it has evolved to live almost exactly like a virus.
And that's really what pulled me in for this deep dive, the whole Trojan horse aspect of it. We aren't just talking about a bug that, makes you sick. We're talking about an organism that has basically stripped away almost all of its own metabolic machinery.
Yeah, it has completely discarded the ability to make its own energy, just to become the ultimate parasite.
It's wild. But I guess it's an evolutionary gamble that paid off.
Oh, massively. If you actually look at the genome of Chlamydia trachomatis, it's incredibly small. It shed everything it doesn't absolutely need because it knows, well, I can just steal those things from the host.
It's the ultimate bad roommate. It's not just living in the house. It's eating your food out of the fridge and using your electricity to charge its phone.
That is exactly what it's doing.
So before we get into the actual mechanics of that theft, which we definitely will, we should probably set the stage on who the players are. Because Murray lists a few different species, and the taxonomy has gone through a bit of an identity crisis recently.
It really has. For a long time, microbiologists were kind of split.
The classic lumpers versus splitters debate.
Right. You had the lumpers who wanted to call everything chlamydia, and then the splitters who wanted to separate the respiratory and avian species into a totally new genus called Chlamydophila.
Which you do still see, right?
Yeah, you'll definitely still see Chlamydophila pneumoniae and Chlamydophila psittaci in some of the older textbooks, or even on clinical lab reports today.
But reading through Murray, he seems to come down pretty hard on the side of the lumpers.
He does, and frankly, I think it makes life much easier for everyone, especially if you're a student studying for boards. The genetic evidence shows that while there are differences, they're all closely related enough to just sit under the chlamydia umbrella.
Keep it simple. So we've got three main characters for this deep dive.
Exactly. First, Chlamydia trachomatis, which is the heavy hitter for human disease. That's the eyes and genitals.
Right.
Then there's Chlamydia pneumonia, which is the respiratory pathogen. And finally, Chlamydia psittaci, the one we get from birds.
Okay, so our mission today isn't just to list out the symptoms they cause. Anyone can memorize a list.
And you'll forget it by next week if you just memorize it.
Exactly. The mission is to really understand the how, because the deeper you read into chapter 35, the more you realize that every single clinical presentation, from the blindness in trachoma to the pneumonia in infants, is dictated entirely by the life cycle of the bacteria.
That is the crucial insight. If you understand the biphasic life cycle, this incredibly unique ability to switch between two distinct forms, then the pathology just becomes intuitive.
You can predict what the disease will look like.
Right, because you know exactly what the bacteria is physically doing at the cellular level.
So let's start right there, the biphasic life cycle. This is the main concept anchor that Murray keeps coming back to. Two forms, the elementary body and the reticulate body.
I like to think of it as a Jekyll and Hyde situation, but, purely for survival.
Yeah.
Let's look at the elementary body first, or the EB. This is the infectious traveler.
Its only job is just to get from point A to point B.
That's it. Its sole purpose is to get from one cell to another, or from one person to another.
And to survive that journey, it needs protection. Murray describes the EB as having a literal suit of armor.
And it's a very sophisticated suit of armor. So since chlamydia doesn't have that typical rigid peptidoglycan layer that most standard bacteria use for structural support, it has to compensate.
Right, because without a cell wall, it would just pop in the environment.
Exactly. So the ED is wrapped in these major outer membrane proteins, which we call MOMP, and another really important cysteine-rich protein called OMP2.
Now, whenever I see cysteine-rich in microbiology, I immediately think of sulfur, which implies disulfide bonds.
Precisely. It is extensively cross-linked. Think of it like vulcanized rubber or a tightly woven chainmail vest. These disulfide bonds lock the outer membrane into this incredibly rigid, impermeable shell.
So it can just sit out there in the harsh world.
Yeah, it allows the EB to survive on a towel, on unwashed hands, or during the rough physical transit through the birth canal. It resists osmotic pressure, and it resists drying out.
But there is a massive trade-off for that armor, right? If you're completely locked in a rigid suit, you can't exactly move around or eat.
Right. The EB is completely metabolically inert. It's functionally a spore, though structurally we don't officially call it a true spore.
Because it lacks the dipoclinic acid and all that classic spore architecture.
Exactly, but functionally it is asleep.
Yeah.
It cannot replicate, it cannot synthesize new proteins. It's just a heavily armored package delivering a payload of DNA.
Okay, so the package arrives. The EB finds a new host cell. And Murray specifies it really prefers columnar or cuboidal epithelial cells.
It's actually very picky. It loves the mucous membranes. So we're talking the conjunctiva of the eye, the endocervix, the urethra, the respiratory tract. The EB bumps into these cells and attaches specifically to their microvilli.
And here's where the Trojan horse trick really kicks in. It doesn't drill its way inside like some parasites. It tricks the cell into opening the door.
It induces its own phagocytosis. It knocks on the door and effectively convinces the human cell to reach out, wrap its membrane around the EB, and pull it inside.
Into a little bubble.
Right, an endosome or a phagosome.
But normally, Immunology 101 says this is where the bacteria dies. The cell swallows it, fuses that phagosome with a lysosome full of acid and digestive enzymes, and just dissolves the invader.
That's what should happen. But chlamydia completely hacks the process. As soon as the EB enters, it secretes these specific proteins, often using a type 3 secretion system, which is basically a molecular syringe.
Just injecting proteins straight through the bubble wall.
Yeah, and those proteins physically modify the host's phagosome membrane. It essentially hangs a do not disturb sign on the door. It completely prevents lysosomal fusion.
So it has created a perfectly secure safe house. It's sitting in this bubble right in the middle of the host cell's cytoplasm, completely hidden from the immune system.
And once it knows it's safe, that's when the transformation happens. This is the shift to the second phase. Over the next 6 to 8 hours, that rigid, disulfide-linked armor starts to break down.
The environment inside the cell reduces those disulfide bonds.
Exactly. The bonds are reduced, the membrane becomes flexible again, the bacteria physically swells up. It absorbs water and becomes the reticulate body. The RB...
Which you could call the naked replicator.
That's a great label. The RB is the intracellular factory. It goes from being totally asleep to being metabolically hyperactive. It shed the armor specifically so it could transport nutrients back and forth across its membrane.
But because it dropped the armor, it's incredibly fragile now.
Oh, totally. If you took an RB out of the host cell, it would burst immediately. It's osmotically unstable. It absolutely must stay inside the safe house to survive.
And this is where the theft we talked about earlier happens. You said it acts as an energy parasite.
This is one of my favorite, most unique features of chlamydia. It possesses an ATP-ADP translocase enzyme. It literally pumps the host cell's hard-earned ATP straight into itself.
Wow.
Yeah, and then it takes its own spent, useless ADP and pumps it back out for the host cell's mitochondria to recharge.
That is spectacularly rude.
It's survival at its most ruthless. And it uses all that stolen energy to replicate by simple binary fission. 1 RB becomes 2, 2 become 4, and they just keep dividing until they completely fill up that phagosome.
Which is what you see under the microscope.
Right. If you stay in the cell and look under a light microscope, you see this massive granular sac of bacteria pushing the host cell's nucleus totally out of the way. We call that an inclusion body.
Which is a huge diagnostic clue. We'll definitely come back to that.
Yeah.
So now the host cell is just packed full of these fragile RBs, but they're stuck. If the cell bursts right now, they'd all die in the harsh extracellular environment.
Exactly. So in a highly synchronized event, which honestly we still don't fully understand, the trigger for the RBs get a signal.
Yeah.
Maybe they realize they're running out of stolen ATP or physical space.
Time to pack up.
Right. They stop dividing, they start condensing, they crank up the synthesis of that cysteine-rich protein again, and they literally rebuild the armor.
Transforming right back into elementary bodies.
Yes. They recross-link all those disulfide bonds. And then, roughly 48 to 72 hours after the whole thing started, the host cell is completely exhausted. It either ruptures or extrudes the whole inclusion.
And hundreds, maybe thousands of newly armored EBs are released into the environment, ready to find new cells and start it all over.
That's the cycle. Invasion, differentiation into RB, replication, redifferentiation into EB, and release.
And understanding that cycle, it just explains so much about how we treat it. Like I was reading the treatment section in Murray, and it suddenly clicked why penicillin is completely useless here.
Ah, the classic chlamydial anomaly.
Yeah, because for decades, scientists thought chlamydia just didn't have any peptidoglycan at all.
Right, which is the specific target for beta-lactam antibiotics like penicillin. We now know from genomic sequencing that they actually do have the genes to make peptidoglycan.
But they don't really use it for a structural wall.
Exactly. They might synthesize a tiny transient ring of it just to help the RB pinch in half during cell division, but they do not have a functional structural cell wall in the traditional sense. The EB relies on its protein armor, and the RB is basically naked inside the host.
So penicillin comes along and essentially has nothing to grab onto.
Nothing to hit. And beyond that, penicillin doesn't even penetrate the human host cell membrane very well in the first place, let alone getting all the way into that protected phagosome.
So to kill chlamydia, you need a drug that can actually cross the human cell membrane, get into the safe house, and target the internal machinery of the naked replicator.
Specifically, you want to target protein synthesis. That's why our heavy hitters are doxycycline, which slips in and binds the bacterial 30S ribosome, or azithromycin, which hits the 50S ribosome. You have to shut down the factory while it's active inside the safe house.
It makes total sense. Okay, so that's a perfect segue into the clinical side of things, because now that we know exactly how it works on a cellular level, we can look at what it actually does to the patient.
Let's do it.
And Chlamydia trachomatis is really the star of the show here. Murray breaks the species down into different serovars.
This is classic old-school microbiology. Serovars are basically just different variants of the same bacteria defined by the specific antigens on their surface. Specifically, differences in that MOMP protein we talked about.
And what's cool is that these serovars map almost perfectly to specific clinical diseases. It's one of the few times in med school where a classification system actually directly helps you figure out the clinical presentation.
It's very clean. Let's walk through the alphabet. We start with the first group. Serovars A, B, B, and C.
The mnemonic here is an absolute lifesaver. A, B, C stands for Africa, blindness, and children. This is the group that causes trachoma.
Right. And I think in the West, we tend to forget about trachoma, but it is a massive global health issue.
Yeah, reading Murray, I was shocked to see it's still the leading cause of preventable blindness worldwide. It is hyper-endemic in parts of North and Sub-Saharan Africa, the Middle East, parts of Asia.
It's heavily associated with poverty, overcrowding, and severe water scarcity. And the really tragic part is the mechanism of how it causes blindness. It's not an acute infection where the bacteria just rapidly eats the eye.
Right. It's a chronic immunological disaster. It's basically a hypersensitivity reaction.
Exactly. The initial infection is a follicular conjunctivitis. You get this red, bumpy, inflamed inner eyelid. Now, if a child gets that once, it might just resolve. But in these endemic areas, the child gets reinfected constantly.
Because flies carry the EBs from one child's tears directly to another child's face.
Yes. Flies, dirty hands, shared clothing, eye-to-eye transmission.
Yeah.
And every single time the immune system ramps up to fight off the chlamydia, it causes intense inflammation. And when that inflammation heals, it leaves a little bit of scar tissue behind.
And this is the crucial mechanical concept for exams. Scar tissue contracts.
Right. Imagine the inner lining of your upper eyelid slowly shrinking over years of repeated scarring. Eventually, it physically pulls the margin of the eyelid inward.
Which is a condition called entropion.
Yes. And because the eyelid is turned inward, the eyelashes, which are supposed to point out and protect the eye, are now pointing directly at the surface of the eyeball.
So every time the patient blinks, they are dragging their own eyelashes across their cornea.
That's called trichiasis. And you can imagine, it is excruciating. Over years, this constant physical abrasion scratches the cornea, causes secondary infections, and leads to severe corneal scarring and opacity.
And they go blind. And the heartbreaking part is that by the time the blindness actually sets in, the bacteria is long gone. The damage is entirely the mechanical aftermath of the host's own immune response.
Which is exactly why the World Health Organization uses the SAFE strategy to combat this. It's not just about handing out pills.
SAFE stands for surgery, antibiotics, facial cleanliness, and environmental improvement.
Right. You need the surgery to physically flip the eyelid back out so the lashes stop scraping. Antibiotics, usually a mass distribution of oral azithromycin to clear the bacterial reservoir in the community. And then facial cleanliness and environmental improvement, like better access to clean water to stop the transmission cycle.
Okay, so that's A, B, B, and C. Moving down the alphabet, we get to the serovars that most people immediately think of when they hear the word chlamydia. Serovars D through K.
The mnemonic here is, well, it's a bit crude, but I promise you every medical student uses it. D through K stands for dick and cooch.
Hey, whatever sticks for the exam, right?
It definitely sticks. These are the urogenital infections. And this brings us to one of the most critical concepts in infectious disease, the silent epidemic.
This is a massive public health issue because the clinical presentation is wildly different between men and women.
Completely different. In men, it usually causes symptomatic urethritis. They get dysuria, meaning pain when they pee, and a urethral discharge. Though usually the discharge is a bit more watery and less profusely purulent than what you'd see with gonorrhea.
So the men usually know something is wrong and go to the clinic.
Right. But in women, up to 80% of infections are completely asymptomatic.
80%. That is a staggering number of people just walking around with an active infection.
It's terrifying because asymptomatic does not mean harmless. The bacteria are actively colonizing the endocervix. Remember, they love that columnar epithelium, and they don't just stay put at the cervix.
They ascend. They travel up into the uterus and directly into the fallopian tubes.
And just like we saw in the eye with trachoma, the immune system becomes its own worst enemy here. The body detects the bacteria in the fallopian tubes and sends in massive waves of neutrophils and lymphocytes to fight it.
Which causes pelvic inflammatory disease, PID.
Yes. The intense inflammation causes collateral damage to the delicate ciliated cells lining the fallopian tubes. Those little hairs are supposed to gently sweep the egg from the ovary down to the uterus. But the inflammation destroys them. And again, the healing process results in fibrosis, scarring.
So you end up with scarred, dysfunctional fallopian tubes, which leads to two distinct devastating outcomes.
Outcome 1. The scar tissue is so severe that it blocks the tube completely. The sperm can never meet the egg. This causes permanent infertility.
And outcome 2 is arguably even more dangerous.
Outcome 2 is an ectopic pregnancy. The tube is only partially blocked, or the cilia are just dead. The tiny sperm manages to swim up past the scar tissue and fertilize the egg. But the fertilized embryo, which is much larger, gets stuck on its way back down.
It implants right there in the wall of the fallopian tube.
Which is an absolute surgical emergency, because as that embryo grows, the tube will eventually rupture. A ruptured ectopic pregnancy can cause massive, fatal internal bleeding. And all of this stems from an infection that the woman likely never even knew she had.
It really highlights why routine screening for young women is so aggressive.
Absolutely essential. Now, there's also a systemic complication linked to these DK serovars that mostly affects men, Reiter syndrome.
Oh, right, reactive arthritis. I remember the classic triad for this: urethritis, conjunctivitis, and arthritis. Can't pee, can't see, can't climb a tree.
It's a great mnemonic, but the interesting thing is the mechanism. Students always ask, why the arthritis? Did the chlamydia travel to the knee joint?
Right, but the joint fluid is usually sterile, isn't it?
Exactly. You usually won't find the bacteria in the joint. It's an autoimmune phenomenon. We call it molecular mimicry. The immune system generates antibodies designed to attack the chlamydia antigens, but those antibodies get confused. They cross-react and start attacking the patient's own connective tissue in the joints, or the uvea of the eye.
And this doesn't happen to everyone. It's strongly linked to genetics.
Yes, it is heavily associated with young men who carry the HLA-B27 genetic marker. If you have that specific immune gene, you have a high predisposition to this kind of autoimmune cross-reaction after a chlamydia infection.
Okay, so we've got A through C for eyes, D through K for genitals. That leaves the last group. Serovars L1, L2, and L3.
L stands for Lymphogranuloma venereum, or LGV.
And this one behaves fundamentally differently than the others. The DK serovars seem totally content just hanging out on the surface of the epithelium. But the L serovars go much deeper.
They are highly invasive. The L serovars have evolved this unique ability to actually survive inside mononuclear phagocytes. Those are the immune macrophages that are supposed to patrol the subepithelial tissue and eat invaders.
So instead of being destroyed by the macrophage, the bacteria just hitches a ride inside it.
Exactly. It uses the macrophage as a taxi to travel away from the initial site of infection on the genitals, straight to the regional draining lymph nodes.
So it specifically targets the lymphatic system.
Yes. In heterosexual men, this usually means the inguinal lymph nodes right in the groin. But the clinical timeline is really tricky. The primary stage starts with a genital ulcer at the site of infection.
But unlike a herpes ulcer, which is incredibly painful, the LGV ulcer is small, transient, and totally painless.
People almost always miss it. It heals on its own in a few days, so the patient doesn't even come to the clinic until stage 2.
And stage 2 is hard to ignore.
Very. The infected lymph nodes in the groin swell massively. We call them buboes. They become extremely inflamed, painful, and they can merge together into this large, solid, matted mass. Murray specifically points out the groove sign.
Right, where the inguinal ligament physically creates a tight depression between the swollen lymph nodes above it and below it, making it look like a double-lobed mass.
Exactly. And if it's left untreated,
It gets worse.
much worse. The nodes become fluctuant, meaning they turn into soft, fluid-filled abscesses. And eventually, they can literally rupture right through the overlying skin, forming these chronic, draining fistulas. It is incredibly tissue destructive.
And we should mention, the presentation changes depending on the site of exposure. In women, or in men who have sex with men, if the primary infection is rectal, the lymphatic drainage goes to the deep pararectal nodes instead of the groin.
That's a vital clinical point. In those cases, the patient presents with severe proctitis, intense rectal inflammation, pain, tenesmus, and bloody discharge. It can actually perfectly mimic the symptoms of Crohn's disease or inflammatory bowel disease.
Which is a huge diagnostic trap, so it's a completely different beast compared to the standard DK urethritis.
Completely different, which is why, as we'll see later, the treatment duration has to be much longer.
Okay, before we leave C. trachomatis entirely, we have to talk about the innocent bystanders, the neonates.
This is the tragic downstream consequence of the silent epidemic. A pregnant woman has an asymptomatic DK cervical infection. She carries to term and goes into vaginal labor. The baby passes through the birth canal, which is effectively coated in millions of infectious elementary bodies.
It's an incredibly high-risk exposure. Murray notes that about 50% of infants born vaginally to infected mothers will develop an infection.
The most common is inclusion conjunctivitis of the newborn.
So an eye infection.
Right. And it usually shows up about 5 to 12 days after birth. The baby's eyelids swell shut, and there is a copious, thick, purulent discharge.
Now, from a board exam perspective, how do you immediately tell this apart from gonorrhea? Because Neisseria gonorrhea also causes severe neonatal eye infections.
It's all about the timeline. Gonorrhea is aggressive and fast. A gonococcal eye infection appears in the first 2 to 5 days of life. Chlamydia is slower, taking 5 to 12 days to really show up. That specific incubation gap is your classic exam clue.
But the eye infection isn't the only risk, right? The baby is also taking her first breaths while passing through that fluid. They can easily aspirate the bacteria directly into their lungs.
Yes, and that leads to infant pneumonia. This usually presents a bit later, maybe 2 to 3 weeks of age, sometimes even up to 3 months, and the presentation is highly specific.
But the baby usually doesn't even have a high fever, do they?
Right, which is weird for a bacterial pneumonia. Instead, they present with this incredibly distinct, repetitive, dry cough. We call it a staccato cough.
Staccato meaning short, sharp bursts, like a machine gun.
Yeah, exactly.
Okay.
It happens because the chlamydia causes an interstitial inflammation. It's deep in the structural walls of the air sacs, rather than filling the actual air spaces with pus and fluid like a typical strep pneumo infection would.
So the lungs just become really stiff.
The baby is breathing fast tachypnea and coughing constantly to try to clear the irritation. But there's no phlegm to bring up because the airways themselves aren't full of fluid.
And if you take a chest x-ray of these infants,
You won't see a big, solid white lobe. You see diffuse interstitial infiltrates. The lungs just look hazy or dirty all over.
yeah.
Also, as a bonus lab finding, these babies often have eosinophilia in their blood, which is unique.
Treating these infants is notoriously tricky because of our antibiotic limitations.
Yeah, we can't use our go-to chlamydia drug, doxycycline, in young children. Tetracyclines bind to calcium and will permanently stain their developing teeth brown and can interfere with bone growth.
So we have to pivot to the macrolides.
Right. We use oral erythromycin or azithromycin, but here is the major clinical trap. You have to treat them systemically.
You can't just give them antibiotic eye drops for the conjunctivitis.
Exactly. Because the bacteria likely also colonize their nasopharynx or their lungs during birth. If you only give topical eye drops, they will clear the eye infection, but develop the pneumonia 2 weeks later. You have to give oral antibiotics to clear the bug from their entire system.
Okay, that comprehensively covers the heavyweight champion C. trachomatis. But Chapter 35 does cover its cousins. Let's shift gears to the respiratory pathogen, Chlamydophila pneumonia.
You'll often just hear it called chlamydia pneumonia now. This is a very common cause of atypical or walking pneumonia, playing right alongside mycoplasma pneumonia.
And why do we call it walking pneumonia?
Because the patient isn't strapped to a hospital bed, gasping for air with a fever of 104. They're usually walking around, going to work, just feeling absolutely miserable. They have a low-grade fever, a persistent dry cough, maybe some bad sinusitis or pharyngitis.
And it spreads exactly how you'd expect a respiratory bug to spread.
Yep, person to person via respiratory droplets. Someone coughs on the bus, you inhale it, the EB infects your lung epithelium.
Standard stuff. But there's this fascinating, much darker side to this specific bug that Murray hints at, a potential connection to atherosclerosis and heart disease.
Yeah, this is one of those wild areas where infectious disease suddenly crashes into cardiology. Years ago, researchers started doing biopsies of atherosclerotic plaques, those fatty cholesterol blockages inside arteries that rupture and cause heart attacks.
And they found chlamydia DNA in there.
They did. They specifically found pneumonia inside the foam cells. Those are the macrophages that engorge themselves on cholesterol within the blood vessel wall.
So the bacteria is physically inside the heart plaque.
Yes. The working theory was that the bacteria infects these macrophages in the lungs, travels through the blood, settles in the artery wall, and causes chronic, low-grade inflammation that rapidly accelerates the buildup of the plaque.
I mean, that sounds like a massive smoking gun, a bacterial cause for heart attacks.
You would completely think so. But here is where the scientific method kicks in. When they organized massive, multi-center clinical trials giving thousands of heart disease patients long courses of antibiotics to kill the chlamydia,
It didn't work.
it didn't change the outcomes at all. It didn't stop the heart attacks or shrink the plaques. So the current consensus in Murray is that the association is clearly there, but the role of the bacteria is not causative. It might just be an innocent passenger that likes to hide inside those specific macrophages rather than the actual driver of the heart disease.
Still, it's a fascinating intersection. And finally, we have the bird bug, Chlamydia psittaci.
Psittacosis, or ornithosis. This is strictly a zoonosis, meaning it's the disease transmitted from animals to humans.
Which animal specifically? Just any bird.
Historically, it was linked to psittacine birds, parrots, parakeets, macaws, cockatiels. But we now know it's incredibly common in standard poultry too. Turkeys, ducks, chickens.
And how do humans catch it? You aren't usually getting bitten by a turkey.
It's all about the droppings. The infected birds shed massive amounts of EBs in their feces. The droppings fall into the cage or the barn, they dry out, and they turn into this fine dust.
Oh, no.
Yeah. The human comes along to sweep the cage or clean the barn, kicks up the dust, and inhales the aerosolized EBs straight into their lungs. It's a classic occupational hazard for pet shop workers, veterinarians, or poultry farmers.
Clinically, does this just look like the mild walking pneumonia we just talked about?
No, psittacosis is much nastier. It starts suddenly with a high fever, severe muscle aches, and a headache that patients almost always describe as severe or splitting. It's a horrible headache.
But the key differentiator is that it doesn't stay in the lungs.
Exactly. It goes systemic. It spreads through the blood and specifically targets the reticuloendothelial cells of the liver and the spleen.
So you get hepatosplenomegaly.
Yes. If you have a patient presenting with pneumonia symptoms, a terrible headache, and on physical exam you find an enlarged, tender liver or spleen, you absolutely must ask them about bird exposure. That unique combination of lungs plus liver and spleen is the dead giveaway for C. psittaci.
Okay, so we fully covered the bugs and the different diseases they cause. Now we have to face the real-world problem, finding them. Why is diagnosing chlamydia historically such a massive pain in the neck?
It all goes straight back to that biphasic life cycle we started with. You absolutely cannot culture chlamydia on standard agar plates in the lab. If you swab a patient's cervix and streak it onto a nice nutrient-rich blood agar plate, absolutely nothing will grow.
Because the bacteria are obligate intracellular parasites. They need living cells to provide ATP.
Exactly. So to grow them, you have to do a tissue culture. You have to maintain a living line of human or monkey cells, often McCoy cells in a flask. You inoculate those cells with the patient sample, put it in an incubator for 48 to 72 hours, and then you have to specially stain the cells with iodine or immunofluorescence just to manually search for those inclusion bodies under a microscope.
Which sounds incredibly slow, highly technical, and extremely expensive.
It is all of those things.
Mhm.
It used to be the gold standard, but it is just completely impractical for mass public health screening.
Well, what about just doing a simple, cheap gram stain on the clinic floor? Can't we just look at the discharge?
That is another classic trap. Chlamydia are technically gram-negative based on their envelope structure, but they do not stain well with gram stain because they are far too small and they hide inside the host cells.
So if a guy comes in with urethritis and you gram stain his discharge,
You will see tons of neutrophils. Those are the white blood cells, the pus. But you will see absolutely no visible organisms. No diplocaci, no rods, nothing.
which in itself is a massive diagnostic clue, isn't it? The concept of sterile pyuria.
Spot on. Pyuria means pus or white cells in the urine or discharge. Sterile means standard cultures grow nothing and gram stains show no bugs. If you see symptomatic sterile pyuria in a sexually active person, you should immediately think of chlamydia. It also rules out gonorrhea, which would clearly show gram-negative diplocaci right inside the neutrophils.
Okay, so if culture is a nightmare and gram staining is useless, how do we actually diagnose it today in 2026?
We use molecular biology, specifically nucleic acid amplification tests, or NATEs, basically PCR.
We stop looking for the bug and start hunting for its DNA.
Exactly. We target very specific DNA sequences, often a cryptic plasmid that almost all C. trachomatis strains carry. These NATEs are incredibly sensitive and highly specific. You get an answer fast.
And the absolute game changer for public health is the sample collection.
Oh, and revolutionized screening. Because the NATE is so exquisitely sensitive, we don't need to do painful, invasive urethral swabs on men anymore.
They can literally just pee in a cup.
Right. We use a first void urine sample. The very first 20 milliliters of urine physically washes the infectious EBs right out of the urethra. The lab extracts the DNA from the urine and amplifies it. For women, vaginal swabs are still the preferred sample, but they can be easily self-collected by the patient in the bathroom. It removes so many barriers to testing.
That makes a huge difference. Finally, let's nail down the treatment. We established early on that beta-lactams like penicillin are out because there's no functional peptidog-lichen wall to attack. We need drugs that penetrate the host cell and shut down the factory.
The two mainstays in clinical practice are doxycycline and azithromycin.
Let's break those down. Doxycycline is a tetracycline class antibiotic. It targets the bacterial ribosome.
Specifically, it reversibly binds to the 30S ribosomal subunit, completely blocking the bacteria from synthesizing the proteins it needs to replicate. The standard course for a simple, uncomplicated DK urogenital infection is 100 milligrams orally, twice a day, for 7 full days. It's highly effective.
And then there's azithromycin.
Right, which is a macrolide that binds to the 50S ribosomal subunit. The massive advantage of azithromycin is its pharmacokinetics. It has a huge volume of distribution and a very long half-life. It penetrates deep into the tissues and just stays there for days.
So you don't have to give it for a week.
Exactly. You can often give a single 1-gram oral dose right there in the clinic. The nurse watches the patient swallow it, and you are 100% sure they are fully treated.
One dose versus remembering to take pills for 7 days. That seems like a compliance no-brainer.
It is, which is exactly why azithromycin was universally favored as the first-line therapy for a long time. However, very recent clinical data has started to show that doxycycline might actually be slightly more effective, specifically for clearing rectal infections. So public health guidelines are currently shifting a bit back toward doxycycline as the absolute first line, but honestly, both are still heavily used.
And what about the complications, like LGV?
For LGV, the L serovars that invade the lymph nodes, a 7-day course is not enough. The infection is too deep, protected inside those matted buboes. You have to give doxycycline for a full 21 days to ensure you clear it.
And we touched on this earlier, but pregnant women are a special population here. We absolutely cannot use doxycycline.
Right. Tetracyclines are strictly contraindicated in pregnancy because they cross the placenta, bind to calcium, and interfere with fetal bone and tooth development.
Yeah.
So for pregnant women, we rely on azithromycin. Historically, erythromycin was the alternative, but it causes terrible gastrointestinal side effects, so patients would just stop taking it.
But the most important part of treating chlamydia isn't actually choosing between doxy and azithro, is it? It's the partner.
Yes. This is the golden rule of STI treatment. Chlamydia is the ultimate ping-pong infection. If you perfectly treat the patient, but you don't trace and treat their sexual partner, the patient just goes home and gets reinfected that very same weekend. You must treat all sexual partners from the last 60 days, ideally simultaneously.
Treat the network, not just the patient. Okay, let's wrap this deep dive up with a little practical application. I've pulled a few rapid-fire recall cases from the archive's theoretical ones to prep for single best answer exams that highlight the trickiest parts of this chapter. I'll act as the quizmaster. Let's see how we approach these.
I am ready. Let's do it.
Question 1. A 22-year-old male presents with dysarthria. He denies any visible penile discharge. A urine dipstick in the clinic is positive for leukocyte esterase, indicating white blood cells, but his standard urine culture comes back at 48 hours as no growth. What is the exact infectious form of the most likely responsible pathogen?
Okay, this is a classic setup for sterile pyuria. The white cells prove there's an infection, but the negative standard culture rules out E. coli. In a sexually active young male, this is a Chlamydia trachomatis urethritis until proven otherwise. The specific question asks for the infectious form, which is the elementary body. The EB is the heavily armored form that survived the transit from his partner. Students should review the biphasic life cycle section in Murray for this.
Excellent. Question 2. A 45-year-old woman who owns a large poultry farm presents with a sudden fever of 103 degrees Fahrenheit, a severe splitting headache, and a dry, hacking cough. On physical exam, the physician can palpate the enlarged edge of her spleen below the rib cage. Which specific chlamydia species is responsible?
The key clues here are the poultry farm exposure, the pneumonia symptoms, and the critical finding of an enlarged spleen. Splenomegaly points to a systemic reticuloendothelial infection, not just a standard lung bug. This is psittacosis. The responsible organism is Chlamydia psittaci. Review the psittaci clinical syndromes in Murray.
Question 3. Which specific serovars of Chlamydia trachomatis are responsible for the leading cause of preventable infectious blindness worldwide?
Blindness points to trachoma, using our mnemonic A, B, C for Africa, blindness, in children. The exact answer is serogars A, B, B, and C. They cause the chronic conjunctival scarring that leads to entropia and trichiasis. That's table 35.3 in Murray.
Question 4. An infant born via unassisted vaginal delivery develops a severe repetitive staccato cough and diffuse interstitial pneumonia at 3 weeks of age. He is a febrile. What is the most appropriate class of antibiotic treatment?
The timeline of 3 weeks, the lack of fever, and the classic staccato cough make this chlamydia infant pneumonia, acquired from the mother's birth canal. Because the patient is an infant, tetracyclines are strictly contraindicated. You must use a systemic macrolide, specifically oral erythromycin or azithromycin, to ensure you clear the respiratory tract fully. Check the neonatal treatment guidelines in Chapter 35.
Question 5. Why are standard beta-lactam antibiotics like penicillin or ceftriaxone generally considered ineffective against chlamydia infections?
Beta-lactams specifically target and inhibit the cross-linking of the peptidoglycan cell wall. Chlamydia are obligate intracellular bacteria that lack a functionally structured peptidoglycan layer in their infectious and replicative phases. Without a cell wall to target, and with poor intracellular penetration, the beta-lactams are useless. You need drugs that hit the ribosome inside the host cell.
Question 6. A patient presents with painful, fluctuant, swollen inguinal lymph nodes. He mentions having a small transient genital ulcer a few weeks ago, which has since healed. Which specific clinical finding of that initial ulcer clearly distinguishes LGV lymphogranuloma venereum from a primary herpes simplex virus infection?
The distinguishing feature is pain. A herpes ulcer is notoriously excruciatingly painful. The primary ulcer of LGV, caused by the L1, L2, or L3 serovars of chlamydia, is completely painless, which is why patients almost always ignore it until the massive buboes develop.
Last one, question 7. What is the current gold standard laboratory method for diagnosing a Chlamydia trachomatis urogenital infection in an asymptomatic patient?
Because culture is technically difficult and gram stains are unrevealing, the gold standard is molecular testing. Specifically, nucleic acid amplification tests, or NATIDES, usually performed at a first void urine sample for men or a vaginal swab for women. They amplify the cryptic plasmid DNA with extreme sensitivity.
Perfect. It is amazing how consistently the underlying biology directly dictates the clinical picture with this bug.
It really does. If you take just one overarching concept away from this entire deep dive, let it be the mental image of that biphasic life cycle. The heavily armored elementary bodies surviving the harsh outside world, and the fragile, metabolically hyperactive reticulate body replicating inside the safety of the host's phagosome. Everything else flows directly from that.
It is the ultimate stealth pathogen. It doesn't actually want to kill you. It just wants to quietly steal your ATP.
A true, perfectly evolved energy parasite.
For everyone listening, if you have your textbook handy, strongly encourage you to go open Murray to Chapter 35. Specifically, spend some time staring at Figure 35.1, the life cycle diagram, and Table 35.3 on the clinical spectrum. Seeing that diagram visually really locks the whole biphasic concept into place.
Absolutely.
I'll leave you with one final, slightly provocative thought to chew on. Chlamydia really is an evolutionary masterpiece. It's a bacteria that looked at the viral way of life and said, yeah, I can do that. Almost all the severe long-term damage it causes, the blindness, the scarred fallopian tubes, the ruptured ectopic pregnancies. It's not actually the bacteria releasing deadly toxins. The damage is almost entirely friendly fire. It's your own immune system blindly destroying your own tissues, desperately trying to evict a squatter that has already built a perfect safe house. Keep those questions coming, stay endlessly curious about the microscopic world, and we'll see you on the next deep dive.
Always a pleasure to be here.